Good day everyone and welcome to my YouTube channel Painfree Partha, and today's topic is about ketamine, the old or the new. Whenever I talk anything on academics, we put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, who's currently our institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry's Director of Sea Dreams. When you go to the history of ketamine, whenever you talk anything on any drug, like it is better to know what happened in the past. Okay. So Maddox and Market Davis company came in a phencyclidine. This is the base of ketamine. But they give so much of phencyclidine in monkeys and then started using in human. But there were a lot of excitatory phenomena. They came with cyclohexamine. Then they started giving 1964 ketamine. See here, there were prison volunteers whom were given ketamine and there was not much of problems like it happened in monkeys. Then they started using ketamine in humans. It is a ketone plus amine. That is a basic. You see here, this is a ketone and this is an amine. That is why it is called ketamine. Ketone plus amine is a ketamine. It is a phencyclidine derivative. It is a weak base with a pK of 7.5 and it is supplied in solutions of hydrochloride salt. It is supplied as ketamine hydrochloride. 10 milligram per ml, 50 milligram per ml, 100 milligram, even preservative free ampules are available where the pH is around 3 to 5. Ketamine is compatible with atropine, which are often mixed. Commercial preparation of ketamine contains a racemic mixture of two isomers. The S-ketamine is coming up now. Now, basically, it is an IV drug. Basically, it can give so many routes, but basically, it's an IV drug. Redistribution, again, the same thing which we saw in the pre-videos of barbiturates. Elimination itself around takes half an hour, but the action almost gets over by 20 minutes. Liver demethylation, diazepam competitively inhibits N-demethylation. So you add diazepam and ketamine, mostly they add, we should know that it may be prolonged. It gets into glucuronide metabolites and into the kidneys down out of the body. Tolerance may occur in burns patient after repeated administration. Now, how does it act? It acts so well. It is being attracted by so many people. NMDA antagonism. This is what the prime thing, especially what is classically described as NMDA antagonism at the thalamo-cortical projection systems. This is what is the mechanism they told for dissociative anesthesia. It stands for even 3 to 4 decades. NMDA antagonism at the level of thalamo-cortical, thalamus-cortical projection systems. This is what is the classically described action. Now they have proved that there are increased glutamate levels. There is some opioid effect. There is some monoaminergic effect. There is some cholinergic effect. So many things are coming up now, but principally it is an NMDA antagonist. There is no GABA A function because your propofol, thiopentone, all these things act by stimulating GABA A and causing the chloride channel to increase and cause depression of neurons. That doesn't happen here. This is an NMDA antagonist. What is the pharmacodynamics? It produces CNS depression to a dissociative state. Profound analgesia. This is what is very important. Classical of ketamine. You have pain relief with ketamine. You don't have pain relief with thiopentone or propofol. Amnesia, even though patients may be conscious and maintain protective airways. So that is why they protect airways. That is some sort of safety given plus a questionable risk. But that's because it protects airway reflexes better. It is not ideally suited for a supraglottic airway device. There propofol is suited. The proposed mechanism is, that is what I told, electrophysiological inhibition of thalamocortical pathways and stimulation of limbic system. The dose is 1 to 2 milligrams. It acts in around 30 seconds. IM dose is around 4 to 8 milligrams per kg. It acts by 4 minutes. People see if you use 2 milligram per kg IM and you don't get the action, we are at fault. Use 8 milligram per kg IM. Mostly it will take some 5 minutes the baby to get under. So this is commonly used where we cannot get IV lines and where we don't have much of sevoflurane, because sevoflurane is a children friendly inhalation agent. So 8 milligram per kg, if you use IM, the patient is under and it should be under observation of anesthetist. Burn dressing changes, debridement, skin grafting procedures, even in fractures, the excellent analgesia, that is very important, and ability to maintain spontaneous ventilation in an airway, that might be useful in these patients. But just because it maintains airway, it gives good analgesia, you should not use in the ward. You should have resuscitative equipment. It should be used only by anesthetist. This is what we should struck in the mind. We cannot use like that, Chuma. Yes, it should be used only in the presence of anesthetist and in the presence of resuscitative equipment. Ketamine have got a lot of other doses. Even previously, we nowadays in 95s, they thought ketamine is epileptogenic. It all became trashed up by its anticonvulsant action. It is used in refractory epilepticus. It is used in sedation. Just this dose is enough, 0.25 milligram per kg. Lower doses even need not need oxygen supplementation, and it is used 2.4 milligrams used in infants. But attenuation of pain and stress response may not be efficient in kids. Caudal adjuvant 1 milligram per kg, but the so-called apoptosis risk is questioning this use of caudal ketamine. Comparison of three anesthetic, sub-anesthetic doses in allaying procedural death. See, if you give spinal, you give three doses, 0.2 milligram, 0.3, 0.4, something like that. So 0.3 milligram per kg is supposed to be ideal, and this is our study published in Saudi Journal of Anesthesia. We conclude. Who concludes? Esparza. Ketamine and dexmed provided adequate pseudoanalgesia for performing block, but dexmedetomidine has advantages in maintaining verbal response. See the cost. That is the difference mainly between ketamine and dexmed. If cost is no problem, and if the infusion pump is there, and we can use dexmedetomidine efficiently and as ketamine also. Ketamine little less or little more sedation than dexmed. Ketamine, by suppressing the induction of nitric oxide, protein expression by endotoxin, anti-inflammatory effect in patients with sepsis. Ketamine inhibits TMF-alpha. Congenital heart disease with right to left shunt is useful because it increases SVR. War footings and other indications. 50 milligram nasal atomizer is available. Battlefield injuries. See that there are so many indications. That is the greatness of ketamine. Ketamine gargle attenuates post-operative throat. We cannot use for thiopentone. We cannot use for propofol. Single dose use, see that CRP is decreased, lower incidence of delirium and cognitive dysfunction after cardiac surgeries. All routes you can use almost. IV 1 to 2 milligram per kg, 0.3 milligram per kg is a subanesthetic or analgesic dose. 4 to 10 milligram per kg starts action IM, oral 6 milligram per kg, nasal 0.7 milligram per kg. They have now approved a new nasal spray for resistant depression, psychiatric. Previously it was psychiatria, ketamine. No. Now they are telling, yes, in refractory depression, use ketamine. Rectal 8 milligram per kg will go up to 15. Epidural, intrathecal, IVRA, adjuvants to blocks. You can see there is no other way out, I think, in anesthesia. IV, IM, oral, nasal, rectal, epidural, intrathecal, Byers block, adjuvant to peripheral nerve blocks. I think these are all the only routes available to us. Maybe one or two may be there for some rare people to use. Children metabolize ketamine faster than adults, and higher dosing is required than in adult population. but elderly means lower dosing. This is not much difference between the other drugs. Now, which is the end point? We know thiopentone, loss of bilateral reflex. We know propofol, verbal contact is lost. Loss of reflex, apnea, verbal contact, not clearly defined. IV actions may be start by 30 seconds and distribution half-life is around 10 minutes. See here, all these things may not be because there may be movement of the eyes, we cannot see anything, and because this is supposed to cause nystagmus. So it is very difficult to think. Patient may be a respiratory stimulant, and if you touch, he may move like this. So all these things make questionable, very difficult. It needs ultimate vigilance to know which is the end point of ketamine. Opioid tolerance is reversed. So patient is in, now a cancer pain is there. Patient is on tramadol 200 milligram TDS with the morphine or something like that, 30 milligram tablets TDS. Now you admit the patient and give an infusion of ketamine for 1 or 2 days. This is what is being practiced. This opioid tolerance is reversed and your morphine 30 milligram TDS for this cancer pain may become effective. This is what is the meaning. I am not going into big RCTs. What do you mean by opioid tolerance? If you go on taking opioids, it will not act. Stop it. Give infusion of ketamine for some time and then give again opioids. Opioids will act. It increases CMRO2, CBF, and ICP. Propofol prior may be useful in blunting ICP. That is what is called ketofol, now famous. Previously, we all used to use midazolam or diazepam only prior to ketamine, and now people started using propofol, a sub-anesthetic, minimal dose, 10 or 20 milligrams, before giving 1 milligram per kg of ketamine. No protection against brain ischemia. Here EEG is not isoelectric, fast beta activity. This is what is important. No isoelectric EEG. We cannot monitor EEG to know the depth of anesthesia. Ketamine as a well characterized. Now you have seen so many actions on the CNS. And now go to RS, it's a bronchodilatory effect. Active bronchospasm, yes, it may be there. There may be some stimulation of respiration. And the most important problem is it increases secretions. This is what we should need to understand. When secretions increase, yes, there may be a bronchospasm. So we need to have glyco, then cut down your secretions, and then use bronchospasm cut off using ketamine. So that is more important than just like that using ketamine. Airway reflexes are preserved, but we should be cautious because silent aspiration has taken place after ketamine anesthesia. We think that airway reflexes are protected, but beware of the airway. Yes, possibly silent aspirations have been reported, which I have seen also. Effective intrapermits high is very important. Now we don't need, so ketamine is an analgesic. Some dose of ketamine we can increase our FiO. Very important. In sick patients, we are giving nitrous oxygen agent. Now you give some ketamine, cut down your nitrous to a little less, and you will increase your oxygen to 50 or 60%. This is possible with ketamine. FRC, MAE, tidal volume, coordinated, all these things are maintained. In the CVS, cardiac stimulating action, direct sympathetic stimulation, that is very important. Increases SVR, vasoconstriction, that is what is important. Reduce the magnitude of redistribution hypothermia. Vasodilatation means propofol, redistribution hypothermia is a problem. If you vasoconstrict, this is different from cardiac. So temperature also, it has got a beneficial effect. Increased heart rate and cardiac output, increased myocardial work and oxygen consumption. So this hits out as patients when there are patients with ischemic heart disease. Danger is being pronounced. Second dose may not cause much changes. Now, if the patient is hypovolemic, ketamine induction is okay. After the patient becomes hypovolemic, for example, in ectopic, patient has got a lot of blood loss. Already the pulse rate is 145 or 150. She is sympathetically exhausted. There, we cannot expect ketamine to produce further tachycardia. It may produce a myocardial depression causing a BP fall. That we should understand. Hypovolemia, normal, yes. Ketamine induction, fine. If the completely patient is sympathetically exhausted, it is not that useful as a sympathetic stimulant. Rapid sequence induction of the shock patient, profound analgesia without concurrent respiratory depression by opioids. Yes, it can be used in children. Anesthetic doses can increase uterine tone. So see, for example, a patient with PPH. Patient is hypotension, shock. We want to use an anesthetic agent to cause hypotension, and we want to use ketamine, uterine tone. That is where it stands. Increase the skeletal muscle tone, increase the salivation, nystagmus. Yes, just because the patient is a kid. Just because the patient is a kid, he's not going like that. We give IM ketamine and the patient is coming for eye surgery. Kid, how will they operate? Yes, that is important. Just because the patient IM kodudana, we cannot do the eye surgeries. Chronic pain, now they have found out it decreases central sensitization and wind up phenomenon and pain memory. This I will talk later in a pain series of lectures of 5 or 6 lectures. Tonic movements may be present during the administration of ketamine. Yes, we should understand that. These movements do not mean additional doses of anesthetics. Sometimes you give ketamine, 1.5 milligram per kg, patient is under, sometimes there is no verbal contact, but suddenly the patient may move. That doesn't mean it is completely needs wait for some time and assess again and then give. This is R ketamine and this is S ketamine, all these in isomers. It is 3 to 4 times potent, less cardiac stimulant, better analgesia, less motor movements, and decreased emergence delirium. I don't know why this drug has not hit the market, but yes, it's a good drug for indications exactly tuned to that. What are the other indications? Sole agent for conscious sedation for a short noxious procedure. For example, a perianal abscess. They are going to do an INT, noxious, painful procedure. Give this thing. No IV line sometimes. You can give IM, and again I'm telling, resuscitative measures and anesthetist should be there. No pain on injection. The most commonly used subanesthetic antidepressant dose over a 40 milligram. Ketamine for ECT now. Ocular effects, nystagmus, diplopia are reported in recreational contexts. Ketamine in the treatment of depressions, pain syndromes, chronic pain, headache, neurological applications including neuroprotection and seizures have slowly been emerging. Ketamine in non-anesthetic doses. Review of non-anesthetic doses of ketamine. Ketamine, new indications for an old drug. All these are coming up now in 2020-21. High incidence of psychomimetic. Yes, we all know that so many effects are there. It has got anesthesia, analgesia, pain relief, acute pain relief, chronic pain relief. Even consciously, patient can undergo some antinociceptive effect. All these things, or bronchospasm is corrected, BP is that doesn't fall. But all these things, even though they are there are some side effects. High incidence of psychomimetic reactions, hallucinations, nightmares, altered short-term memory, 10 to 20%, is dose dependent and can be decreased by 2 to 5 milligram of diazepam. Yes, what I always use is only diazepam still now before ketamine. I am personally not very convincing with midazolam 2 to 2.5 milligram that dose you have to use to cut down this. Yes, in this way or something, in decreasing the hallucinations of ketamine, I will prefer diazepam rather than midazolam. Yes, the people nowadays use propofol. Start from 1 hour. Emergence phenomenon is an exam question. Start from 1 hour at recovery. 1/3 of adults and women are higher. Sometimes in present in children, they are more prone in patients where they have already psychological problems. Atropine increases, benzodiazepine decreases. We have to be careful about promethazines. Sometimes these may also increase the incidence of emergence phenomena. Music makes it pleasant. Here you see one-third of adults. Adults and women higher rather than children were present problems. Psychological problems previously. Atropine increases because there is already a difference. Atropine crosses blood-brain barrier while glyco does not cross blood-brain barrier. More common side effects associated with ketamine are nausea, vomiting, diplopia, drowsiness, all these things. Hypertension, tachycardia, arrhythmias, apnea, laryngospasm, rarely skin rashes. Now we have got so many side effects related to CNS, related to CVS, related to eyes, related to vomiting, all these things. Intraocular pressure may be detrimental. This is what I told. Vitreoretinal surgeries. It can be used in malignant hyperthermia. It can be used in porphyria. Ketamine has a dose-dependent effect, 6 milligram causing a small increase. Say the patient is already under halothane. It doesn't do much. Only we cross 6 milligram per kg, the danger starts. This is one study. Ketamine can produce, yes, this is what is more important. So many diabetic patients are coming now. They come for an INT. They come for a small debridement use. They are all on TCATs. Many people you can see sertraline because they have neuropathic pain. They are all on amitriptyline, imipramine and all. So we have to be careful about using in these diabetic patients. Take care. Understand the history. Go to the history. Take the tablet of drug history. TCATs are available. Then we should be careful. What are the contraindications? Already we have told. Because it increases BP, it causes problems in heart, ischemia, all these things it is not. Open eye injuries, I have already told. This is all the some of the contraindications. The dose matters. Again telling cardiovascular sedation is not much a problem. That is what in 2021 it tells. Nothing in acute alcoholism. Many actions are said. Combined use and abuse dangers because we are using use of ketamine, abuse of other drugs. Beware. So why should there need a resurgence of ketamine? Low dose is good. Anesthetic adjuvant. Yes, we can give some ketamine and decrease your nitrous oxide intraoperatively. Analgesia is very good. You can use procedural sedation, postoperative pain reduction, chronic pain reduction, inflammatory changes, cancer effects, inflammatory effects on sepsis. So many things are coming up new for ketamine. There are not much. We can use anything like root is IV, IM, intrathecal, epidural, subcutaneous, intranasal, sublingual, so many efforts that are there. Decreasing the incidence of emergence agitations, undergoing dental repair. You see, people think that emergence agitation is ketamine is more, but if you selectively use a small dose before sevoflurane anesthesia, this agitation is decreased. The sevoflurane associated emergence problems are decreased. Pain in the emergency room also reduces the severity of pain in migraine. Give some intranasal ketamine. Autism, intranasal ketamine. Mood in social interactions, improvement. Rectal ketamine has got a delayed onset, but it's as effective as sedating before general anesthesia. Oral ketamine, 6 milligram per kg. Long-term subcutaneous infusions, neuropathic cancer pains. Subcutaneous infusions at the injection low dose, 0.5 milligram per kg in cesarean sections. Use a combination of low dose epidural with morphine. Why not morphine alone? Give some ketamine also. Some ketamine also. You can decrease your morphine. Use of intrathecal ketamine in two difficult doses. We had one ischemic heart disease with hernia. We got a big lipoma there in the back. There we can give. So intrathecal ketamine actually produces level-free analgesia. We can have little T1, T2 also. So the lipoma was done with intrathecal ketamine. There is one patient with ischemic heart disease. This was done long back. See, the publication is 1990s or something, 2008. So this must be 15 years back. So where all these drugs like Dexmed, all these things have not come. Intrathecal ketamine as 1 milligram per kg produces sensory and motor block. Psychomimetic inadequate short duration precludes its use as a sole anesthetic. Now you see, even RAPM they have used 1 milligram per kg. There are so much of psychomimetic disturbance, inadequate analgesia, and short duration. Add midazolam. This is what we have been practicing, and I have used at least minimum of some 2,000, 3,000 cases of a combination of intrathecal midazolam and ketamine, where I don't find any psychomimetic disturbance or any duration of action problems. Low dose midazolam to low dose bupivacaine links. Ketamine and midazolam. This has been published in 2016. I have not got the data now. Ketamine and pulmonary edema, yes, because it increases. This is put up by us, Indian Journal of Anesthesia, 2009. So we had ketamine IV. Sometimes in patients, there was a frothy sputum after that. These are two cases from common surgeries. Yes, we should understand. That is why I'm telling always we should have resuscitative equipment and should be given by the anesthesiologist. Ketamine enhances. See here, peripheral action by bupivacaine. If you give a block, you add ketamine, it enhances bupivacaine actions. Preemptive analgesia with ketamine for laparoscopic surgeries. This is also another article. Some extra dose are then added to preemptive. There are so many other things. So preemptive ketamine. 2 milligram per kg possible improvement in block characteristics. Adjuvants in sympathetic blocks. For example, you give a lumbar sympathetic block or sometimes a stellate ganglion block. You add ketamine. So there are innumerable, countless, high-level indications of ketamine and uses of ketamine. Analgesic effects of topical ketamine. This was available previously. I have used it, but suddenly it got away from the market because of ketamine became a very narcotic drug and it came under the Drug Prohibition Act. There are amitriptyline, ketriptyline. This contains ketamine 1%. Formula ketriptyline is there. Ketarax patch, ketamine hydrogel mic needle patch. These are all another transdermal therapeutic systems. So we can have iontophoresis, we can have transdermal therapeutic systems also with ketamine. Iontophoretic administration of S-ketamine in intractable central pain, a placebo-controlled trial. You see here, that is what I decreased my list with IM, IV, subcutaneous, intrathecal, epidural, rectal, all these things, nasal, oral. See here, iontophoresis, transdermal, so many things are there. IVRA, sublingual, local, better than next med in few studies. One study questions the extras. Sublingual ketamine for chronic neuropathic pain. Ketamine ointment for neuropathic pain. So it is history. It is not history. Ketamine itself is history. Preparations. It is ketone plus amine. Preparations are there. Routes are there. Indications. Special effects. These special effects means it has got analgesia effect. That is what we should tell. It can be given with different routes. It increases IOP. It increases SVR. These are all the special effects. Complications, yes, we should know about pulmonary edema, heart failure in patients, already risky patients. Contraindications, already we have saw ischemic heart disease and uncontrolled hypertension. These are coming up with old and new indications. And thank you all.